Hello, good morning.
Good morning, Doc.
Okay, we proceed.
Yes, we can see the presentation.
All right, fantastic. We are going to be able to achieve the following: understand the biology, life cycle, and the mode of transmission of amoebiasis and typhoid. Understand the causative organisms. Largely, we're going to deal with Entamoeba histolytica, and we also look at typhoid, and then understand the pathological processes that lead to disease in amoebiasis. Amoeba, these are unicellular organisms with full functions. The distribution is wide in soil, in water, other surfaces. There are more than 65,000 species, and I know you've covered this in parasitology, and the majority are free living, and the ones that are parasitic are about 10,000 species. That's a lot. Pathogenic protozoa, majority of them are opportunistic parasites. They are not normally pathogens, but they become pathogenic due to impairment of host resistance. And here you have clinical importance in the HIV or AIDS patients. The basic structure of amoeba is that they have a plasma membrane. They have a cytoplasm, which has an ecto and an endoplasm. The ecto is mainly has a locomotive and ingestive functions, and the endo is where metabolism occurs. There is nucleus, either a vesicular form or compact form. Locomotive organelle. Please mute your devices. Locomotive organelle, we know we have the pseudopodium, the flagellum, and cilia. The most important pathogenic intestinal amoeba is the Entamoeba histolytic. The trophozoite is the infectious type. They are usually 10 to 40 micrometers in diameter. The shape is ovoid with pseudopodium. The basic structure, as we say, the cytoplasm, vesicular nucleus, with chromatin granules and nuclear membrane and karyosome. And here we're able to see the nucleus. We can see the ectoplasm. You can see a red blood cell in a food vacuole. And this is the way we determine to know whether they are infectious or not, because when you have them having this, then you know that they are infectious. And you can see the size using this grid that we have. Here you have them. They also have chromatin. The nucleus could be up to 4. Now, there is a cyst form, apart from the trophozoite form. The trophozoite is the infectious type. The cyst is 10 to 20 micrometers. The structure has a wall and 1 to 4 nuclei with chromatoid bodies. Physiological function, depending on the stage of discharge, they are resistant to external surroundings, then they transform to become infectious stage with time. Usually we have a cyst, ingestion, then transforms to a trophozoite, which releases or becomes more cysts, or cysts and cysts. The host is the human being. It lodges in the large intestine, so in the colonic. Importance in the HIV or AIDS processes. Hello, good morning.
Good morning, Doc.
Okay, we proceed.
Yes, we can see the presentation.
All right, fantastic. We are going to be able to achieve the following: understand the biology, life cycle, and the mode of transmission of amoebiasis and typhoid. Understand the causative organisms. Largely, we're going to deal with Entamoeba histolytica, and we also look at typhoid, and then understand the pathological processes that lead to disease in amoebiasis. Amoeba, these are unicellular organisms with full functions. The distribution is wide in soil, in water, other surfaces. There are more than 65,000 species, and I know you've covered this in parasitology, and the majority are free living, and the ones that are parasitic are about 10,000 species. That's a lot. Pathogenic protozoa, majority of them are opportunistic parasites. They are not normally pathogens, but they become pathogenic due to impairment of host resistance. And here you have clinical importance in the HIV or AIDS patients. The basic structure of amoeba is that they have a plasma membrane. They have a cytoplasm, which has an ecto and an endoplasm. The ecto is mainly has a locomotive and ingestive functions, and the endo is where metabolism occurs. There is nucleus, either a vesicular form or compact form. Locomotive organelle. Please mute your devices. Locomotive organelle, we know we have the pseudopodium, the flagellum, and cilia. The most important pathogenic intestinal amoeba is the Entamoeba histolytic. The trophozoite is the infectious type. They're usually 10 to 40 micrometers in diameter. The shape is ovoid with pseudopodium. The basic structure, as we say, the cytoplasm, vesicular nucleus, with chromatin granules and nuclear membrane and karyosome. And here we're able to see the nucleus. We can see the ectoplasm. You can see a red blood cell in a food vacuole. And this is the way we determine to know whether they are infectious or not, because when you have them having this, then you know that they are infectious. And you can see the size using this grid that we have. Here you have them. They also have chromatin. The nucleus could be up to 4. Now, there is a cyst form, apart from the trophozoite form. The trophozoite is the infectious type. The cyst is 10 to 20 micrometers. The structure has a wall and 1 to 4 nuclei with chromatoid bodies. Physiological function, depending on the stage of discharge, they are resistant to external surroundings, and then they transform to become infectious stage with time. Usually we have a cyst, ingestion, then transforms to a trophozoite, which releases or becomes more cysts, or cysts and cysts. The host is the human being. It lodges in the large intestine, so in the colonic parasite. Infective stage is when they have 4 nuclear cysts, and usually it's orophycal, contaminated when we put through our mouth contaminated food material. Susceptibility generally considered to affect children and adults of both sexes equally. However, some data and anecdotal evidence suggest a male predominance. This is purely from hygiene because male will tend to just eat mandazi without cleaning their hands, and maybe motura. Maybe liver abscesses are most common in males, also ages of 18 to 55. These are the most productive men. These are the people who are outdoor a lot of time. And yes, as we indicated, they may eat more motura. Susceptibility to liver abscess conferred by HLA-DR3 and complotype SC01 in the Mexican populations. Other risk factors include oral and anal sex. I'm not uncomfortable saying that, but anyway, maybe you too. And contact with contaminated enema apparatus in the health facilities. This is a stool preparation, and we are able to see a nucleus and the cysts. Pathogenesis. Amoebic trophozoites invade the colon, causing colitis. They may also invade the portal circulation and travel to the liver, hence causing liver abscesses. The spectrum of colitis includes one. You see mucosal thickening. There is more, and these are gross when you do colonoscopy or autopsy specimen. You see multiple cyst formations, diffuse inflammation and edema, necrosis and perforation of the colonic wall. Trophozoites invade through the submucosa, causing flask-shaped, flask, the ones we use in the lab, cysts or ulcers. Cystine proteases released by the trophozoites digest extracellular matrix in the liver and colon and induce interleukin-1 mediated inflammation. Proteases also cleave IgA and IgG antibodies, disarm the host immunity system. Binding of Entamoeba histolytica to epithelial cells via gal-lectin. This molecule shows homologous to human CD59, conferring resistance to complement system. A change in the epithelial permeability is induced, probably via the intercellular tight junctions. Cell lysis and apoptosis of mucosa are thought to be mediated by amoeba force, and the amoeba pores peptides are peptides capable of forming pores in lipid bilayer cells. So there you get what? You get leakage, lysis of the cells, leakage of intracytoplasmic content, hence apoptosis and ulcer formation. Once you have necrosis of the apoptosis of the cells, then you have an ulcer formation. The neutrophils and macrophages are drawn to the invasion sites, and Entamoeba histolytica can lyse neutrophils, leading to further tissue damage and contributing towards the induction of diarrhea. Inflammation is a significant cause of tissue damage. However, innate immunity may be the main combatant against amoebiasis. So strong innate immunity is going to be useful here. Maybe colitis, basically you see edematous, you see very red mucosa. You can find ulceration and perforation. This is a normal mucosa. This is an attempt to demonstrate the flask-shaped. So this is the mouth of the flask. This is the neck, and then this is the base. So these are flask-shaped, wide base, narrow neck, and then a top, a mouth of it, filled with inflammatory debris. These are the necrotic cells and mainly leukocytes. Yeah, so this is a base, the bottom, this is a neck and the mouth of the ulcer, and it's usually within the submucosa. So these are the classic flask-shaped, these are flask-shaped ulcers. You see them in neglected cases in patients with poor immunity, as we have noted. The ulcers tend not to perforate through the colonic wall. They're usually submucosal based, but when you have low immunity and high burden of infection, you may have then complicated perforation of this. This is quite different from other lesions like Crohn's. Crohn's, you get to have fissures that go all the way, and with granulomatous inflammation. You have ulcerative colitis that is a little bit more superficial lesion. Hepatic pathology, trophozoites invade the colonic mucosa. Invading the colonic mucosa may enter the hepatic circulation and reach the liver, as we have seen before. Well-circumscribed abscesses are formed in the liver containing liquefied cells surrounded by inflammatory cells and trophozoites. Adjacent parenchyma is usually normal. This liver and this abscess right here, and you have multiple abscesses. Metastatic amoebiasis, as you can see, this is an amoebic abscess. Get to the lung. So we have metastatic amoebiasis. From the colon, you get the liver is the most common. They can go to the lung. They can also get to the brain. So in summary, the life cycle, we know what happens. We do have pre-cyst forms released. These are non-invasive luminal form, encystation. They pass out through feces, then ingestion of food with food or water. We have excistation of tetranucleate amoeba in small intestine. We have metacystic amoeba, and then we have the binary fission and the invasive form within the colon. From there is when you develop the disease, which is the colitis, as we have seen the pathology. And the main complication is metastatic disease. Local complications usually is ulcer with dangers of bleeding as well as perforation. In summary, the pathologic mechanism is contact lysis between the pathogen and the mucosa. And the main pathology you see, they are the flask-shaped ulcers. Clinical manifestations could be non-symptomatic in carriers, and intestinal amoebiasis presenting as dysentery and colitis. Extraintestinal amoebiasis you find now liver abscess, lung, and brain metastases or abscesses. Diagnosis, mainly very quick stool analysis, where we are able to identify either the carrier forms with cysts or the active forms. And then you have colonoscopy with biopsy. At colonoscopy, you're able to see the ulcers. You take biopsy, you can see the trophozoites with erythrocytes inside, and you can now clearly indicate and confirm there is amoebiasis. Good. We're still on time. We're going to touch on typhoid. It's prevalent in many geographical regions in the world. We can see the highest intensity are within the tropics, mainly Africa, Asia, and South America. The famous Mary, Typhoid Mary, is a famous example. Is a Mary Malone, who was a food handler responsible for infecting at least 78 people, killing 5 of them. These highly infectious carriers pose a great risk in public health. That's why all food handlers have to be routinely examined, both blood, stool, and blood analysis, just to make sure that they're not infectious. Typhoid fever is a bacterial disease caused by Salmonella typhi. It is transmitted through the ingestion of food and drink contaminated by the feces or urine of infected people, fecal-oral route, basically, just like amoebiasis. Paratyphoid fevers are produced by other species of Paratyphi, A, B, C. The bacteriology, this you know better. The genus Salmonella belongs to Enterobacteriaceae. They are facultative anaerobes, which are gram-negative bacilli, and they are distinguished from other bacteria by biochemical and antigens. The bacteria has two sets of antigens. We can detect this through serotyping. We have the O, the somatic antigens, which contain long-chain polysaccharides, comprises of heat-stable polysaccharide commonly, and we have the flagellate or H antigens that are strongly immunogenic and induces antibody formation rapidly and in high titers. Following infection or immunization, the flagellar antigen is of a dual nature occurring in one or two phases. And this is important. When you're checking for amoebiasis, we look at the titers. So if you're doing a serum test for the presence of antibodies, you want to look for, you're looking for antigens, you're looking for H. If there are antibodies, you're looking for anti-H. And when you look for titers, you want to demonstrate a rise in titers or very high titers. Otherwise, ordinarily, you're always going to find some anti-H antibodies being present due to low-grade disease. The main now causes mainly is the typhi, but you can have paratyphi also present. The organism penetrate the ileal mucosa. We have said is orophycal. And we can see where the ileum is. And why the ileum? The ileum is where you have very slow movement of contents, of intestinal contents, because that's where maximum absorption of food material is. And that's where you also have the valve, which is which slows the flow to allow absorption naturally. This is a place where you have maximum concentration of pairs patches. And so the organisms penetrate the ileal mucosa. For those reasons, they reach the mesenteric lymph nodes via the lymphatics. They multiply within the lymph nodes. They invade the bloodstream via the thoracic duct with a lymphatic drainage. In 7 to 10 days post-infection, you have through bloodstream infection of the liver, reside in the gallbladder, the spleen, the kidney, and the bone marrow. After multiplication, the bacilli pass into blood, causing secondary heavier bacteremia. All the events coincide with fever and other signs of clinical importance within 2 weeks. There's a step ladder pattern of fever. There's abdominal symptoms, which is soup, pee, diarrhea, plus or minus constipation. There's a rose spots, which is a skin rash, tiny rose-colored spots on the skin in lighter subjects. There's relative bradycardia. This is a patient who has fever, but the heart rate is not as high as we anticipate in other febrile patients. And also you have now splenomegaly. So these are the cardinal clinical features of enteric or typhoid fever. So primary pathology at the intestine. We have already established that at the terminal ileum or at the ileum is where we have the slow flow. That's where you tend to have a lot of pairs patches, the mesenteric lymph nodes. So the terminal ileum and the cecum, they are the 4 stages. Number 1, you have hyperplasia of the pairs patches, then you have necrosis of the overlying mucosa, you have ulceration, and finally, you have recovery. So these are the Peyer's patches. They are within the submucosa. This is a muscle layer. This is the mucosa of the ileum. So stage 1, first stage, which is the first week, you have hyperplasia of the Peyer's patches. You can see this longitudinal patch, which is hyperemic, edematous, and inflamed or swollen. And usually the phagocytes in the Peyer's patches of the ileum and the solitary lymphoid follicles, they proliferate and they are hyperplastic. So these are the phagocytes within there, the histiocytes. And at macroscopy, at gross, all you see is projection of the Peyer's patches usually on the mucosal surface. Usually the mucosa is flat, but now you have well delineated projection on the surface. Microscopically, typhoid granuloma with a large number of typhoid cells, and these are type of histiocytes, the typhoid cells. You're going to see them. Clinical picture is that the blood culture is highly positive. When you do stool culture, you're not going to be able to pick much. So week 1, you want to do blood culture. So this is now is postmortem picture where you see the prominent longitudinally aligned Peyer's patch that is prominent. Clinically, when you're doing colonoscopy, you see the same picture. You're going to find these pictures in your, definitely in your practicals. Stage 2, which is the second week, then you have necrosis. Yellow, greenish brown, which necrosis, which occurs from the center laterally or peripherally. Here you start getting now release of bacteria into the lumen. You get blood culture is still positive in week 2, and you start having positivity of the stool. Week 3, you have ulceration after necrosis of the surface mucosa, then you have ulceration, where you find rounded or oval deep ulcers whose long axis is in the direction of the long axis of the bowel. So they are longitudinal ulcers. These are typical finding in typhoid at macroscopy. When you examine this, you're doing photo, and when you're doing either autopsy, when you're doing colonoscopy, this is the nature of the ulcer, longitudinal, along the long axis of the intestine. And you can compare this with what we call transverse ulcers. Transverse ulcers will have the ulcer along the short axis or radial like this. And those ones, you find them in tuberculosis. So that is the difference. That's why typhoid rarely causes stricture, while TB causes stricture formation. By this time, then you have the stool culture becoming quite positive and white dot test being positive. So week 4, we have seen this was week 3. We transform, we start healing. And here, mainly you want to depend on white dot. At microscopy, at cytology level, these are the transformed histiocytes. These are the macrophages or histiocytes. We call them the typhoid cells. You're able to see them. They have, within them, they have lymphocytes. These are nucleus of the histiocyte. These are nucleus of the histiocyte, but they are engulfing other inflammatory cells. These are red cell within this. These are normal nucleus of the macrophage, but it has a erythrocyte inside. Here you have the normal nucleus. Here you have another inflammatory cell. So that's the typical cells which they demonstrate erythrophagocytosis. So these are famous typhoid nodule or granuloma, which is the hallmark histologic finding in typhoid fever. You find this in the Peyer's patches and in the surrounding lymph nodes. Okay, complications of typhoid fever. And already you have seen throughout the 4 stages, the tests that you need to do, what serology or stool or blood culture that you need to do. Mainly WIDO is it's stage 3 and 4, which is week 3 and 4. Stool culture, you start from week 2, mainly strong week 2 and 3. Blood culture, you want to do it in the first week. That's it. So severe intestinal hemorrhage and intestinal perforation is one of the complications. And if not diagnosed, usually typhoid is lethal. Majority of people have developed immunity, so you never hardly see very severe disease. Apparently, I had an autopsy this year of a gentleman who was being treated for he'd been in hospital for a while and he was being treated for, can I remember, but something different. Maybe peptic ulcer disease. He was released, he went home, then he was not feeling good. And he was transferred from Western on his way to Nairobi. He died on the way. At autopsy, I just found perforated ulcers, and they were classic typhoid ulcers, confirmed by histology, and the bleeding was a lot. The other complications is relapse. Apparently, recovery can be followed by relapse in up to 10% of untreated patients. Morbidity and mortality, if untreated, you may have mortality of up to 20% of the subjects. Salmonella carriers, you have Salmonella enterica, causes approximately 16 million cases of typhoid fever worldwide, and it may kill up to 500,000 people per year. That's a high number. So diagnosis, we have seen blood culture in the first 2 weeks, or really in the first week, but you can do it in 2 weeks. Stool culture in second and third week. Urine culture also in the first week. You can do bone marrow. WIDO test week 3 is very good. Week 3 and 4. You can have clot agglutination test. You can do PCR and other tests. Fantastic. We did well. That was a very fast learning, but I hope you've gotten the concept. As we agreed from the beginning, I expect you to understand the pathogen, the biology of the pathogen, and that you're carrying forward from microbiology, parasitology. The next thing is the mode of transmission. How does one acquire the disease? After that, the important thing will be the pathogenesis and the pathology. The question is, why do we need to do the stool test at week 2 specifically? We're talking about the shedding. We're looking at the shedding of the point at which you have shedding of the bacteria from the mucosa. In week 2 is when you have necrosis. When you have necrosis is when you're having shedding now of, is when you have most of the shedding of the bacteria. So week 2 and 3, you have most of the shedding. Week 4, there's recovery of the wound, there's less shedding. And there you need now to look for need to do now the serology test, the WIDO test. So I expect you to understand those concepts of all the transmission aspect, the life cycle of those bugs, who gets them, the clinical features, then the stages of the disease. How do they penetrate the mucosa? The mechanisms of penetration. Is it cell lysis? Who is predisposed? Okay. for typhoid is very classic, very specific, very much misdiagnosed. Yes, so very quickly, if you walk outside the city where people tend to have better testing, when you go to other counties, you're going to find every patient coming to you, they have no fever, they have just a bit of a headache, which is persistent, and they are told it's typhoid. You're given a report that says wide or positive. No titers that are given. They have been unwell for 2 months. Then you need to do better investigations. Do not treat the patient based on that. They could be having a different disease that we're missing. This patient may just be having hypertension. Their bowel habits are normal. So you need to be able to relate the clinical presentation with the disease manifestation and the biology of the disease. Good. Any other question? All right, we sign out.
Yes, doctor. Thank you so much for the class.
You're welcome.
We will meet again.
All right.
Oh, I think there's an extra question. What is the role of SAT? Or what is it?
What's the role of?
Yeah. SAT.
What is SAT?
I have no idea.
A
Salmonella antigen test.
Okay. Yes. This you do on blood. So it's in the group of the white dot test. So you're looking for any agglutination. You're looking for any agglutination to be able to see whether there is antigen. We're looking at the H. You do both H and O, but we have agreed that H is the main antigen that we're looking at, which shows aggressiveness, and you still need to do the titers.
Okay, doc. I guess you answered that.
All right.
Have a good day, doc.
Fantastic. Is there a stool one? Yes, there's a stool test. You can do that. You can do the test also in stool where you can check for the antigen.